Well, thank you for having me. My name is Dr. Taon. I'm representing the U.S. Air Force out of San Antonio Military Medical Center, trained out of Kaiser Permanente, Los Angeles. A true joy to see a lot of my friends, colleagues, mentors here. Very humbling. I have disclosures with Penumbra, and I'm tasked with talking about trauma intervention. Now, trauma correlates the entire body, so it's a little bit much to talk about in 8 minutes. So I wanted to focus on a very unique splenic trauma case we had this week on call, and I'm still on call at this very moment. Now, when you think about splenic trauma, the American Association for Surgery and Trauma have a grading system for multiple solid organ injuries. My patients are going to come to me for angioembolization if I see arterial contrast extravasation, pseudoaneurysms, arteriovenous shunting, vascular cutoff sign, or AAST grades 4 and 5 on the CT. Now, as soon as I see those, I take them for angioembolization, evaluation, and I have a few choices, either proximal embolization or distal embolization, depending on the severity and type of injuries. If I see multiple parenchymal lesions, I tend to do a proximal splenic artery embolization, embolizing at this green highlighted area between the yellow highlighted dorsal pancreatic artery and the teal highlighted pancreatic magna artery. But if I see a single or a few parenchymal lesions, I'll get out as distal as possible and embolize those focally. Now, in our patient, 42-year-old man, motor vehicle collision, positive alcohol, positive cocaine, identified to have a splenic artery pseudoaneurysm, as you can see on the coronal, perisplenic hematoma, high density perisplenic contrast extravasation. Referred to IR for a splenic artery embolization. However, interestingly and additionally, he does have a micronodular liver surface, gynecomastia, concerning for cirrhosis, but also splenic vein occlusion, splenomesenteric varices with surrounding high-density hemorrhage. No esophageal varices, no gastric varices, no periumbilical vein. We take him for our bread and butter splenic artery embolization. And as you can see, I think here on this image, see a lot of tiny contusions, all these tiny circles all over the spleen. The entire spleen has contusions all over it. We don't see contrast extravasation, but because of the diffuse injury, my colleague decided to go with, it's somewhat of a proximal coil embolization, going just proximal to the pancreatic magna here. However, patient continued to crash despite this splenic artery embolization. He actually utilized 80% of San Antonio Military Medical Center packed red blood cell supply and was still requiring max pressors despite this treatment. So trauma surgery colleagues took him back, midline laparotomy. They identified massive hemoperitoneum that erupted from their laparotomy site. They packed him aggressively, could not find an obvious source of bleeding. Despite packing, continued to have a slow ooze, but they could not find a massive hemorrhage. So they packed him, IO-banded him, as you can see here, sent him back to consider TIPS because of that micronodular liver and possible transvenous obliteration, embolization for a possible hemorrhage. So we took a very careful look at his imaging again, and we identified, all these varices are present overlying the spleen. The spleen has diffuse injury. This is highly concerning for a traumatic splenomesenteric variceal hemorrhage, traumatic hemorrhage. Now, this differs from the usual intraluminal variceal hemorrhage. Usually when we think of varices, they're bleeding into the lumen of the bowel, as you can see here on the screen left. But this is highly concerning for traumatic variceal hemorrhage. And although the patient did have some consideration of cirrhosis, we were more concerned about sinistral portal hypertension. We could see the splenic vein occlusion. We could see the splenomesenteric varices. So we decided to go with a CARTO, coil-assisted retrograde transvenous obliteration. Now, when I'm thinking about portal hypertension and shunting, things can get very complex. This patient did have a splenorenal shunt, highlighted here. He also had a continuation of those shunting through a mesenteric vein to the left common iliac vein, and highly concerning for hemorrhage at this inferior spleen site where all these varices are located. Now, when I was training under Dr. Vatican here, this idea of 4D flow MRI helped me get a better understanding of the complexity of portal vein flow. 4D flow MRI can give you the exact direction and velocity of portal vein flow, and they've even correlated it to risks of variceal hemorrhage. This patient didn't have that, of course, it's trauma, but it's important as an adjunct for your education. Now that I see variceal hemorrhage here, we have the choices of TIPS versus CARTO. And kudos to Dr. Casadaban for discussing this earlier. Because this patient was more concerning for a sinistral portal hypertension, we decided to go with a CARTO. And some of the data, especially out here from my UCLA colleagues and mentors here, see a number of strong names here, can be very effective. CARTO, very effective for treating variceal hemorrhage. So we attempted right internal jugular vein access, attempted to access the left renal vein, the splenorenal shunt. Here we can see some of those varices, that large splenorenal shunt, but could not get through. Multiple attempts were made. These varices, these shunts are very tenuous. They got their valves, and so we perfed. You can see this perforation here. It's all right. You know, we continue to move on, keep fighting. We addressed that left common femoral vein access. So this is our access. This is us attempting to access that left mesenteroiliac shunt. Oh goodness, we're able to get it, but we're finding multiple efferent outflow veins. So in order to try to get back into the shunt, we do this coil-assisted transvenous obliteration. This is where we place a coil to try to occlude flow. We have a more central microcatheter to help us with injection. And that gives us clues as to where to go to get more central, get closer to the portal vein, get closer to the central component of the varices. This is what I want you to identify, and something why that 4D flow MRI studies helped me. I injected through the microcatheter, and I see efferent outflow going both ways. I placed this coil here to try to identify where the inflow might be coming from. Now, if flow is going in these directions, and I see subtle reflux here, I'm suspicious that this is the afferent inflow site. So we go in, we interrogate that. We inject it here, and it looks like we got into some prior site. Well, whenever you're in IR and you're in question, you do an oblique, and you can see that oblique. We actually did get into the splenorenal shunt from the mesenteroiliac shunt. We get in there. We did a coil embolization, onyx embolization of that entire splenomesenteric varix. That was the site of hemorrhage, which we saw in the CT scan. Now, of note, anytime I'm doing these CARTOs, PARTOs, my goal is to completely embolize all the way to the portal vein. Because as Dr. Casadaban discussed, if you do this retrograde transvenous obliteration and the patient has worsening portal hypertension, you could get new hemorrhage. A new varix could rupture. Unfortunately, we did not see all the way to the portal vein, but we emboled as much as possible. Outcome. Patient survived the night. No further transfusions. Most likely we got the culprit bleeder, but it continued to require pressors, max pressors, rising lactate. Family was able to arrive, see their family member alive, but in his condition, they decided, shared decision to comfort care only, DNR. They requested no further interventions. Ultimately, they decided withdrawal of care. Patient died within 12 hours of the IR intervention, although he did live to see his family. This brings us to one component of trauma IR care that not necessarily always educated on. That's the ethics of trauma care. You're dealing with urgent decisions. You're not able to discuss with family. And in a level 1 trauma center, if you have a mass casualty situation, you got to be very careful what kind of resources you're utilizing. That takes us to the concept of distributive justice. Make sure you're trying to care for the best case scenario despite multiple casualties. You're also getting emergent consent. So this article here from one of my mentors, Dr. Vairavamurthy. Very helpful framework here. And so something I learned from this case, something because I haven't seen a traumatic variceal hemorrhage, is that if you ever see varices overlying any organ which has undergone trauma, you better evaluate for a traumatic variceal hemorrhage. Varices, although they usually bleed intraluminal, they can also rupture into the peritoneum, hemoperitoneum. And this is one image from an open surgical case where the varix had ruptured into the omentum, the mesentery itself. Even though we did splenic artery embolization, that can be used to treat portal hypertension and varices. I'm wondering if we should have addressed this with a TIPS or cartoparto initially before he started crashing. Something that's very helpful, I would recommend reading up, trying to understand how portal hypertension and varices flow and form, and something to consider immediately before you're in the traumatic setting is what kind of ethical considerations you should address.